Hi again and welcome to the second video on peripheral arterial disease. In this video we're going to diagnose and manage our patient with PAD. So let's get started. So if you have a patient in which you suspect that he's having peripheral arterial disease, based on the risk factors he has and based on the signs and symptoms he's presenting with, which by the way you can check out in the previous video on peripheral arterial disease where we discussed this extensively, you need one diagnostic test, and this is called the ankle brachial index, ABI. So this is a number that you get when you divide the ankle blood pressure to the brachial blood pressure. Okay, so for the ankle blood pressure, you need to measure the blood pressure either in the dorsalis pedis or in the posterior tibial artery, and whichever blood pressure is higher, then you take this value. So the dorsalis pedis artery is on the dorsum of the foot and the posterior tibial artery is behind the medial malleoli. So you measure the blood pressure there with the blood pressure cuff and a Doppler, and you divide the blood pressure, the higher of these two, to the brachial pressure, which you also measure with blood pressure cuff and a Doppler ultrasound. Alright, so and the number you get, by the number you get, you can diagnose peripheral arterial disease. So let's see now here. If the number is less than 0.4, then you diagnose severe peripheral arterial disease. If the index is between 0.41 and 0.90, then you have mild peripheral disease. If this index turns out to be between 0.91 and 0.99, then you have borderline peripheral arterial disease. And the normal ABI is between 1 and 1.4 or 1.3. You know this now, and you can diagnose peripheral disease or rule it out. But what if the test is equivocal? What if you cannot determine if the patient is having PAD or not? Then you can use the exercise ankle brachial index. So basically what you do is you let the patient exercise a little bit and then you measure the blood pressure, the same blood pressures again. And if the value that you had before the patient exercise drops down with more than 20%, then the value after the patient exercises, then you diagnose peripheral arterial disease. Basically, if the ABI drops down, decreases with more than 20% from the initial ABI resting value of the patient, then you diagnose peripheral arterial disease. Alright, so now there is the question of if the ABI is more than 1.4 or 1.3. So this is the tricky question here. So when you see this falsely elevated value, then you have to start thinking of arterial calcification, most commonly seen in diabetic patients with long-standing diabetes and end-stage renal disease. So the artery there will be so calcified that it won't be able to collapse under pressure. That's why the index will be very high here, will be falsely elevated, more than 1.3 or 1.4. And in these cases you have to measure the toe brachial index, and if the toe brachial index is less than 0.7, then you can diagnose peripheral arterial disease. And as we discussed in our previous video, there are a lot of risk factors that can lead to the formation of peripheral arterial disease in patients. So we have to treat the risk factors, right? And because these risk factors are pretty much the same as the ones that can lead to coronary artery disease, that's why peripheral arterial disease is considered to be a coronary artery disease equivalent, then we have to treat the risk factors first, right? So major risk factors is smoking in male African American patients. So if you can stop the smoking, it will be great, it will have huge impact. Now, stop smoking. Also, control the LDL levels. You want to decrease the LDL levels to less than 100 milligrams per deciliter. And here I would like to show you again the 10-year ASCVD score, the atherosclerotic cardiovascular disease score, because it's very heavily tested. So in patients with history of acute coronary syndrome, stable angina, stroke, transient ischemic attack, peripheral arterial disease or CABG coronary artery bypass graft procedures, if these patients who have these diseases and are less than 75 years of age, then they need to get high intensity statin, and the high intensity statin are rosuvastatin and atorvastatin. In patients who are more than 75 years of age, then they need moderate intensity statin. Now, if the patient has LDL more than 190 milligrams per deciliter and he is more than 20 years of age, then he also gets high intensity statin every time. If the patient is diabetic and is between 40 and 75 years of age and his LDL levels are between 70 and 189 milligrams per deciliter, if their ASCVD score is more than 7.5%, then they get high intensity statin. If their ASCVD score is less than 7.5%, then they get moderate intensity statin. And the last group here are patients with no diabetes mellitus between 40 and 75 years of age with LDL levels between 70 and 189 milligrams per deciliter. So these patients, if they have ASCVD score more than 7.5%, they get high intensity statin. If their ASCVD score is between 5 and 7.5%, they get moderate intensity statin. And if their ASCVD score is less than 5%, they get no statin therapy. Also, you want to put the patient on antiplatelet therapy. You can choose between aspirin and clopidogrel. They decrease the cardiovascular disease mortality a lot, so you must put the patient on aspirin or clopidogrel. You also want to control the blood pressure in patients with PAD, especially if they're hypertensive. Here the goal blood pressure is less than 130/80, and your first drug choices are thiazides, ACE and ARBs, and calcium channel blockers. Also, there was this trial, it was called the HOPE trial. They studied ramipril in PAD patients, and they concluded that if they give ramipril in patients who are asymptomatic or symptomatic with PAD, then this ramipril decreases the cardiovascular mortality, so keep this in mind. Also here I would like to update you, if you don't already know about this, about the 2017 guidelines, new hypertension guidelines from the American College of Cardiology and the American Heart Association. So since 2017 the normal blood pressure is back again to less than 120/80. Elevated blood pressure is considered 120 to 129 over less than 80, and hypertension is divided into two stages. Stage 1 hypertension is blood pressure of 130 to 139 over 80 to 89, and stage 2 hypertension is considered to be equal or more than 140/90. And if the patient is diabetic, you want to keep their diabetes under control with HbA1c levels less than 7. Now let's see how can we relieve the symptoms in a patient with chronic claudication. So the first thing you want to do is put them on a supervised exercise program. So they should be exercising at least 3 days a week for 30 minutes for at least 3 months. And they should be on supervised exercise. Basically, they should be walking on a treadmill or somewhere else, but they should be supervised always. And why do you want to do that? Because you want to create collateral circulation that can supply blood to the exercising muscle through an alternative way and not through the stenosed artery. Alright, so if the exercise does not help, you can try giving them cilostazol. So the cilostazol is your go-to drug. It's a phosphodiesterase E3 inhibitor, and as such acts as a vasodilator and as an antiplatelet drug. So you have to try giving them this one. But also don't give them in patients with a reduced ejection fraction and history of heart failure. And the other drug that you will see on the STEP exams as an alternative to cilostazol, they're gonna list all of them there, is the pentoxifylline. Remember that the pentoxifylline is inferior to both exercise and cilostazol. So if you can choose between cilostazol and pentoxifylline, always choose cilostazol. If your patient fails to improve on the therapy that we just discussed, they might end up needing surgical or endovascular revascularization. So the surgeon can go into the stenosed vessel and they can open it up with a balloon or put stent there, or they can even create a bypass graft which will bypass the stenotic part of the artery. Also, patients who need surgical intervention are the ones who have pain at rest, who have lifestyle interference, who have non-healing ulcers, who have disabling claudication, and who present with acute limb ischemia. Now, acute limb ischemia we discussed in the previous video, but remember, these patients will present with the famous 6 Ps. pain, paresthesia, poikilothermia, which means coolness, pallor paralysis, and pulselessness. Now, these patients should be treated emergently because irreversible myonecrosis will happen in 4 to 6 hours. In the early postoperative period, you have to watch out for the formation of compartment syndrome, very tested on the USMLEs, and you have to be aware of this syndrome for your future clinical practice. So the patient will present with pain out of proportion and pain on passive leg stretch. Also, there will be rapidly increasing swelling and early paresthesia, feelings basically of pin and needles. And you can actually calculate the compartment pressure and you can figure out if there is a compartment syndrome or not. So there is this delta pressure, which if it's less than 30, when you subtract the diastolic pressure and the compartment pressure, is diagnostic of compartment syndrome. So remember, when you subtract the diastolic pressure and the compartment pressure, this is called delta pressure. If the delta pressure is less than 30, you have diagnosed compartment syndrome and you have to go in there and perform fasciotomies to relieve the pressure. And one super important side effect of compartment syndrome is actually renal failure. Renal failure, remember, they're going to test you on the exams and you're going to see it in your clinical practice. So why is it happening? Now imagine when the pressures in your leg are so high, there will be no blood flow to supply your muscles. So when there is no blood flow to your muscles, they will start undergoing rhabdomyolysis, anoxic muscle necrosis, anoxic muscle injury, and they're going to start breaking down and releasing myoglobin. So this myoglobin will be filtered by the kidney, yes, and the myoglobin will directly damage the proximal convoluted tubules and you also form tubular cast with the thumb horsefly proteins. Alright guys, so this is the end of the second and last video on peripheral arterial disease. I hope you found it useful. Please leave us a comment, subscribe to our channel if you're new here, and also hit the bell button to receive notifications when we upload new videos, which normally happens twice a week. Also, please feel free to check out our other videos on our channel, as I believe you will find useful information there for your USMLE tests preparation and for your also internal medicine residency practice. Again, thank you very much for watching, good luck and see you on the next video.